Welcome everybody to this week's ECG of the Week tutorial. Here's our clinical vignette from earlier in the week. Feel free to pause it so you can remind yourself of some of the characteristics of our patient before we go on. So let's take a look at this patient's ECG. What you'll notice here is that we have two different ECGs, and that's because there's a drastic change between the first and second one. So let's go right away to our rate. Okay, it looks pretty regular. So what we'll do is zoom in and do the 300 method. There's our first RR interval. And let's go 1, 2, about 3 boxes. So 300 divided by 3 means about 100 beats per minute. Okay, the rhythm looks regular. Okay, P waves. We look and we can see a distinct P wave before every R wave. So not only are P waves present, but they are in a 1-to-1 ratio with our R waves. Next thing we're going to look at is QRS complexes. Let's take a different lead. We want to know if they're narrow or wide. We look here and we can see about 1.5 boxes, so that is below 3 boxes or 120 milliseconds. So we'll call that narrow. Next thing is the PR interval. Okay, let's go back to our rhythm strip and we'll start right here at the beginning of the P wave and we'll count 1, 2, 3, 4 small boxes. So that is less than 200 milliseconds or less than 5 small boxes, and so we'll call that normal. And the next thing we'll look is ST segment. Okay, and looking at the ST segment in multiple leads, we can't see any changes from the isoelectric line, and so we'll call that normal as well. So coming to our next ECG, this one happens immediately after the first, and the first thing that you should be able to notice is that the rate is significantly higher. So let's zoom in, look for an R wave on the edge of a big box, count how many big boxes. 300 divided by 2 is 150. Trust me when I say this is a regular rhythm, but what you could do is the paper method seen in previous videos to identify or verify that the rhythm is regular. Third thing, always check for P waves. Zooming in, P waves not apparent in any leads. One thing you will notice after the R wave is this negative deflection consistently after every R wave, and we can discuss that later, but that's a significant finding. So what we'll say is P waves not present. QRS interval, QRS wave. We want to see the width less than 3 small boxes. That's about 1.5 to 2 boxes, so that is normal. PR interval. Since we don't have any P waves, this is not applicable. And ST segment, we'll zoom in, find the isoelectric line, start here, here. There's almost no difference between the ST segment and the isoelectric line. So we'll call this normal. So why do we have 2 ECGs? Let's move on and compare them. The second one is significantly faster than the first one. Both are regular. We've lost our P waves in our second one. Both QRS waves are normal. The PR interval obviously doesn't exist in our second ECG. The ST segment is normal, and the interpretation of each, therefore, is very different. In our first one, we can confidently call that normal sinus rhythm. In our second one, supraventricular tachycardia, or AV-NRT. So what is SVT or PSVT, which is the global diagnosis that we see in this patient? SVT describes a tachyarrhythmia originating above the ventricles. Okay, these arrhythmias are classified based on how they're propagated and therefore how their waveforms look on ECG. PSVT, or paroxysmal supraventricular tachycardia, is when there is an abrupt onset and offset of an SVT arrhythmia. Therefore, are two ECG tracings describing right before the onset and right after the onset. PSVT is often seen with reentry tachycardias such as AVNRT and AVRT. If you just look to the left of the slide, the first diagram depicts what we call AVNRT. So that's AV nodal reentry tachycardia, using the node to continually propagate a signal in a tight little circle, while AVRT, or atrioventricular reentry tachycardia, uses the entire space of the right side of the heart to create another rhythm. Okay, PSVT is commonly seen in young women and should be on your differential diagnosis when a young woman comes in with a rapid heart rate or palpitations. Some interpretation tips when looking at SVT or PSVT. The key features are tachycardia and a narrow QRS. Why is the QRS narrow? Because the signal is coming from above the ventricles and going through the Purkinje fibers, thus leading to rapid propagation of the electrical signal. The rhythm can be regular or irregular. P waves may be visible, absent, or hidden. In our case, as you can see here, the P waves are somewhat hidden or buried after the QRS, and that's because the signal is coming from low down inside the atria, creating a P wave that's going in reverse and leading to a negative deflection. With very fast rhythms, you may see ST segment depression, but that should not be used as a diagnostic tool. So let's take a look at some examples. Here's a supraventricular tachycardia that is of the AV-NRT variety, and one of the key features here is in leads 2, 3, and AVF, you'll see that P wave coming after the QRS signal. Okay? If we look at AVF, we see the same thing here, and if we zoom out and look at lead 3, once again, there's a little dip. Okay? Here's a supraventricular tachycardia with an extremely high rate of about 300. One notable feature of this wave is the fact that your T wave is completely taking up the space between each R wave. And that's simply because there's almost no distance here. If we were to use our rate and count from one big box to another, 300 divided by 1 gives this person a rate of 300. And so most features on an ECG will be obscured by the high heart rate. Here's SVT with a phenomenon called QRS alternans, and what QRS alternans means is varying height of the peak of the R waves. This often happens in cardiac tamponade when the heart is sitting in an inflamed cardiac sac with fluid inside the pericardial space, and the heart muscle is bouncing back and forth on each beat, creating that oscillation. But as you can see here, that P wave is becoming hidden by each R wave because it's originating so low inside of the atria. So, what are the takeaways for SVT and PSVT? When assessing tachycardia, use the width of the QRS complex to ensure yourself that it's coming from above the ventricles. A wide QRS indicates a ventricular rhythm and therefore is not labeled SVT. Use the P waves and the regularity of the QRS complexes to narrow your differentials. Young women with palpitations on a beta blocker are often patients who are receiving treatment for PSVT. And PSVT denotes a tachyarrhythmia with rapid onset. So at one moment, the patient is feeling fine, and suddenly they can feel their heart bouncing out of their chest. Unless you catch this transition inside the office, a thorough history and a Holter monitor are often required for diagnosis. Thanks for watching, and we'll see you next week for our next case.